to the next case, which is high risk complex graft CTO PCI by Dr. Mohan from KMCH Hospital, Coimbatore. Very good. 3, 4. How many from Coimbatore? Very good. Coimbatore is doing more cases than Mumbai. Huh? Looks like that.
Thank you, sir.
So, Dr. Mohan.
There is a high-risk complex IVS guided image-guided SVG2 LED graft CTO PCI in a single surviving graft patient. And this is a scenario which has been happened in 2005 and 2018. 63-year-old male with effort angina, class 3 in 2015, and diagnosed to have a native calcific left main triple disease, for which he underwent a 3-vessel graft, which is venous graft. And subsequently in 2018, that is 13 years later, he had an honest elevation MI. That time angio showed 100% occluded SVG to PDA and 99% subocclusive lesion of SVG to OM and patent SVG to LED graft. And so for which I have done a SVG to OM graft in 2018. And this is a native LMCS CTO where you could able to see the thing. It's a completely calcified ostial left main 100% CTO lesion, and this is a RCS CTO lesion, and this is a graft of SVG to LAD in 2018, and the subocclusive lesion of SVG to OM. This is for which I have done a PTCA through radial artery at 2018. You can able to appreciate that SVG to OM PCI. So this is a 2021 scenario, that is after 3.5 years, and effort angina class 2 to 3, and newly diagnosed diabetes, normal LV function, and again angio showed the native calcific left main, but this time 100% occluded SVG to LAD graft, and as well as already occluded PDA, and only the patent SVG to OM graft is available. So now the plan is we have given the option of high risk redo CABG versus high risk complex image guided rotablation or IVL assisted left main CTO antegrade PCI versus high risk complex SVG to LED graft CTO PCI. So I went ahead with this is the angiogram of that patient. Again, you could able to see the thing native calcific left main CTO and RCS CTO and SVG to OM graft with the patent stent. So this is again multiple views of that patent disc graft to assess the LAD retrograde flow. And so the plan is native calcific left main CTO PCI. So the patient and patient attendants opted for this. And so bifemoral femoral artery access, 7 French and as well as left side 5 French, and SVG to OM graft injection for a LAD antegrade entry, and wire escalation from the Gaia wires to with the MC support. If it get failed, then the Conquest Pro 12 with the MC support. Again, if it get failed, then plan for retrograde CTO PCI or a graft CTO PCI. And subsequently with the pre-dilatation and regular workhorse wire, then I was guided image PCI to finish up. This is what the plan of action. And so now I've been through the right femoral artery access. You could able to see the thing that a dual injection, and so you can able to appreciate the LAD retrograde flow. And subsequently the SVG to OM graft injection for LAD assessment has been done. And this is a native calcific left main CTO where there is a small stump which has been there at the ostium. And this is a various way of technique that used for to cross the true entry into the true lumen, but which were being failed. So multiple times it is with a false true or a true false lumen entry. And with the microcatheter support, microcatheter was initially not supported. Then the portion of one which is went in, and subsequently I could not able to pass the microcatheter. So finally it been landed up with the failed antegrade technique. And here you could able to appreciate that there is a dissection plane, and the here there is no MC support is supporting at the ostium of the left main. And so here with the minimal cross of the wire with the MC support, And the subsequently I could not able to, it's been looking like the wire is in a true lumen, but it is not, the microcatheter is not passed. And the retrograde injection to confirm the antegrade wire, but again it is not in the exactly in the true lumen and partially in the false lumen or in the branch vessel distally, and I could not able to negotiate it. So finally, I'm after the 4 hours of this work, I am forced to stop this antegrade CTO PCI with the native vessel. So now I have left out with the option of either I have to go ahead with the retrograde or I have to do a high risk CTO PCI, that is with the SVG. And there is no good retrograde channels are available. There's a lack of confidence in view of single surviving graft, and planned for complex high risk graft CTO in the same sitting, and a trial with the JR4 guiding catheter. Suppose if it is get failed, then AR1 guiding catheter, then Y has been accelerated from field XT, then subsequently to the Gaia series with the MC support, then the pre-dilatation, IVS assessment, and disc deployment. This is what the plan. And so I went ahead with the initially fielder XT wire, then subsequently with the microcatheter, I exchanged it with the Whisper extra support wire. Then the pre-dilated the entire SVG to LED graft. And you can able to see the thing, there is a diffusely diseased graft with no flow at the native vessel of the LED, that is mid LED. So to confirm the mid LED flow, so I have with the microcatheter, I have given injection. So I confirmed that there is a flow at the LED. Then subsequent IVS has been done. I have to choose the size of the stent because there is a, if you see that 2018 that angio, that SVG2 LED graft is having a multiple level of segment, that is ectatic segment and the very narrow segment and the different size of that SVG vessel. So for the example that I have been given the 2018 how it looks like and the 2021 how it looks like. So now the thing is I have to do the choose the size of the stent. So what I have done is so I have been like the IVS was totally been misguiding me, but we all know the thing IVS in SVG definitely it will have a false impression. So with the combination of the previous the 2018 graph and the IVS, I have chosen the average size of 3 into 38 millimeter stent at the ectatic segment first, then subsequently overlap with or the above one, then the next with the osteoproximal the graft with the 3 into 18 millimeter, then everything being post dilated, and you can able to appreciate that there has been reasonable good flow. And so this is the 2018 SVG to LED graft. This is the 2021 the post PCA graft. So they both been now it's been looking similar. And so this is a couple of views for that post PCA views, and you could able to appreciate that there's a good flow on the SVG2 LED flow. This is the IVS. The pre-distal MLA is 1.75, then the subsequently 3.67 millimeter square. Good luminal gain. The pre-ectatic segment, you can able to see that 4.5 millimeter, then the 10 millimeter. And a native LED block, this is for the IVS information. And there is a smaller post segment, a longitudinal area. And then after that, which has been well opposed with post dilatation serially with the serial balloons. And this is a pre-PCA complete IVS and as well as the post-PCA IVS. And so final coronary angiogram is SVG2 LED with a TIMI3 flow. This is a 2018 ECG and as well as the 2021 post-PCA ECG. And the thing is, final words are, am I right here? Total contrast is 450 ml. Total procedure time is 6 hours. Total radiation is around 9,800 milligray. And no guideline inclusion of graft PCA anywhere. And native versus CTO graft PCA, no randomized trials available so far. There is anecdotal case volume being there, and less effective than native vessel definitely, and lower success rate and higher complication rate, especially doing the SVG CTO, and poorer long-term outcomes in the form of mortality as well as MI and TVR. So my positive thoughts were only perseverance of mine, and I was guided PCI, and no other alternative option I have, and confidentiality of the family members towards me, and a good Timothy flow, graft flow, and I have a bit of overconfidence that there is a good patency of the SVG to OM graft PCI with ongoing 36 months and so on. And thank you so much.
Yeah, but I think some of his colleagues are possibly attending. Whatever said and done, just few comments on the case. Well, congratulations for such a successful case. Very complex case. It is like a chip CTO, I would say, and many issues in that to be discussed. But unfortunately, Dr. Mohan is not there. So whenever we have a CTO in the native vessel in a post-CABG case and the graft is closed, there are 3 or 4 options of how you can do this. So, but the most important fundamental principle is to try and restore the native vessel if possible. Both, I mean, native vessel first.
नहीं वहां से नहीं, यहाँ से मैं करके आता हूँ 15 मिनट में.
Okay. Anybody who is doing the case and possibly going to join us in 15 minutes. So anyway, so the fundamental is to first try and see whether you can open the native vessel, because the long-term patency of the native vessel is more longer than the graft, especially the SVG graft. If it is Lima, then of course the life is still longer. But native vessel, yes, is important. If you can't do that easily, and if you easily can put in a through the vein graft and open the native vessel as he did in this case, then in his case, I would have also, before putting a stent from vein graft to the LAD, I would have gone retrograde into the LAD and opened up the left main LAD. If that could have been done, which would have been possible. Actually, I had presented a similar case just a couple of months back in Indo-Japan CTO, where from the Lima to the retrograde LAD, I opened up left main LAD CTO of the ostium and then restored the native flow. So similarly, if you can do that, well and good, but otherwise this was also a salvage situation. But I think today or tomorrow he should think of a retrograde approach, going from the vein graft to the LAD, retrograde into the left main and open, because there are 3 or 4 important septals in his case. And that also would be causing basal ischemia, if I am not mistaken, if you were to do a thallium test. Nevertheless, that is one. And then secondly, he said the vein graft size was small. So maybe about 25 years back, we had presented in a TCT conference the IVUS of vein grafts and showed that vein grafts can go negative remodeling. Just like artery, the native arteries, the vein grafts also can go negative remodeling. So that's also a very important feature. So I think there are many things to discuss, but for the want of time, this was just a few important comments which I